Hello there, I'm Dr. Michael Graham, and today we're going to be talking about intermetatarsal neuropathy, commonly known as Morton's neuroma. And what we want to discover is why is it that a perfectly healthy nerve becomes diseased, and what can we do to prevent that, to help that, to treat that? So if you have any questions along the course of this, please do submit those to us online. You can always email us at info@gramedica, GRAMEDICA.com. Yeah, go to the website. We have an amazing website for surgeons out there called HyProCureDoctors.com. You'll see that listed on the bottom of the slides. And we look forward to hearing from you in your interaction. So let's get started with intermetatarsal neuropathy. So this story, and this is pretty much what we have, it all begins back in 1876. At that point, the United States was 100 years old. Colorado was just admitted as the 38th state. Wild Bill Hickok was killed actually in a poker game in Deadwood, South Dakota. All kinds of crazy stuff was going on then. Thomas Edison received a patent for his mimeograph. The president at that time was Ulysses S. Grant. The Baseball League was formed. Alexander Graham Bell was granted a patent for the telephone. Heinz tomato ketchup and Budweiser hit the market for the first time. And our hero of this story, Thomas George Morton, published his paper back in January of 1876 on a peculiar and painful affliction of the fourth metatarsal articulation. And this is in the Journal of Medical Sciences. And that's a picture of him, and he's actually buried in Philadelphia. So, and I always love to talk about that historic stuff. But anyway, so what are the presenting symptoms? What is the complaint that we're talking about today? Well, the first thing, of course, is somebody has a burning in between their toes, usually under the bottom of their foot. It's sharp, shooting, and they really don't have any history of trauma. They didn't step on anything. There's no puncture, there's not a foreign body. It just seems like all of a sudden they started walking and they developed this pain in between their toes. They notice that when they don't walk, that there's really no pain or symptoms whatsoever. But then when they start walking, then that's when it becomes very painful, and it just seems to progressively getting worse. So that's kind of what the symptoms we're dealing with this. And it can actually occur in multiple interspaces, and we're going to talk about that later on. So if somebody comes in with this burning, sharp shooting pain, of course you're going to go through your history and physical examination, but then the real important part of this is how to diagnose it, because how can you treat something without a proper diagnosis? So you're not going to really take an MRI for everybody. But that leads us to the kind of second phase of this story, which is commonly called the Mulder sign. And this is where you specify an inner space and you compress the foot medially and laterally, and you kind of feel this click, and you can reproduce that painful symptoms that the patients were talking about. So this is the original article that Mulder wrote back in 1951. This was 75 years later, and he discussed about this palpable click that can be felt in between the metatarsal bones. And that's interesting, and that's great, and that is very, a great way to lead to a suspicion of the intermetatarsal neuroma. But what the main thing that I wanted to bring out about this article was the discussion part of it. And again, let me go back here. I mean, the discussion is basically one paragraph. This is the entire article, 2 pages. So it was not a big, massive chapter in somebody's textbook to talk about the Mulder sign. But anyway, the most important part of this, which was about, again, almost 75 years since this article came out, was the etiologic discussion, that it is the abnormal mobility of the metatarsals giving rise to widening of the bursa between the metatarsal heads. And this creates space into the plantar tissue where the nerves and vessels are located, which are pinched. And then that leads to, with this motion between the metatarsal heads. So, and then he goes further to say, repeated trauma produces swelling and a fibrotic reaction in and around the nerve, and that's what leads to the tumor formation. So when you're treating a condition, you need to focus not just on symptom amelioration, but we need to go back to first cause orthopedics. And this is what I always talk about in the majority of my lectures, is that we need to find out the underlying etiology. Because if we don't address that, no matter what treatment we give our patients, of course, the symptoms are just going to reoccur. So we have this repeated trauma on the nerve. So the second part of our discovery in this discussion is to find out what leads to this repeated trauma that happens most commonly in the fourth interspace, the third and fourth interspace. So let's go back and talk about neuromas. So what is a neuroma? Now, it's really, we're not dealing with a true neuroma, which in the neurological world. But anyway, it's a benign tumor of the nervous system. So it just means it's a tumor that's found along the nerve. Of course, it's non-cancerous, but it is a neoplasm. A true neuroma is something that happens once a nerve has been severely traumatized, usually after one instance versus repeatedly. And so again, this is going to happen in the area where the nerve is injured in an uncontrolled manner that results in a lump of unorganized axonal fibers and non-neuro tissue growth. It means like we don't get a whole bunch of nerves growing out of it. Basically, it's a scar tissue that's forming around the nerve. So again, there has to be some kind of initiating trauma. This type of nerve tumor is a response to trauma. This doesn't happen for the heck of it. Something stimulated this to happen. Something made it happen. So let's look at the anatomic review of nerves, because that's going to help to specify why one area of the foot has a higher rate of this formation than other feet or other interspaces. When we look at the specific cross-sectional anatomy in between the first metatarsal interspaces, we have a lot going on in there. And so we have, of course, the skin on the top and the bottom, fatty tissue above and on the bottom, some muscles that are on the side, but within the interspace itself, we have the interosseous muscles. And then below the interosseous, we have the deep transverse intermetatarsal ligament that's trying to hold everything together. And then there's a septum that goes, connects to the fatty tissue and to the skin to, again, try to help hold everything in place. So in this area, plantar to the deep transverse intermetatarsal ligament, that's where we have our nerve and some small blood vessels and some other supportive cushiony tissue in there. And then on either side of that, we have some more tendons that are going out to the distal end of the toe. Okay, so we have this small boxed in area that that should be, again, used to handling any kind of pressure if it is under an ideal situation. So what we have with this neuroma formation is that it's an unideal. We have some kind of pathology that's happening that's traumatizing the nerve. So let's keep digging deeper. This is also another cross-section that I thought would be really interesting to show you. So A over here, of course, is the first metatarsal head, and then we just go all the way across to the fifth, fourth, third, and the second. And right in here in the third interspace is something that's pretty unique versus the fourth interspace or the other ones. And we have the medial and lateral column of the foot. The lateral column of the foot, which has the fourth and fifth metatarsals, is a stable column. It has very little motion. But the medial column of the foot, this has motion. So the medial column moves pronates, supinates on the lateral column. And so if we have excessive medial column motion, then that can lead to strain and trauma within that third metatarsal space. Now, let's go back, and I'm not going to do a deep dive into nerves, but it's really important because, again, a lot of times we're stuck in private practice and we see the big picture, and every once in a while we need to be reminded of the real amazing structure of these peripheral nerves. So we have this nerve that is bound up with a countless number of smaller axons surrounded by the Schwann cells and the endoneurium, perineurium, and we have the blood flow within that, that is bringing sensory information from the external environment up to the central nervous system. And what's important is that the actual fiber, the axon here that carries that nerve transmission, is surrounded by this glial cell called the Schwann cell, which is extremely important for nerve health. Okay, so that's about as much as I'm going to get into it for right now. But the Schwann cell, so that takes us, here's Dr. Schwann, who was really an amazing guy. If ever you have time, take a look, do an internet search on him, and he's discovered quite a lot. He was over in Germany. But anyway, in 1839, he discussed about this covering around the axon that helps to provide all kinds of support for nerve transition. So this was named after him. So the actual cell itself is a neurolimocyte, and it's a glial cell of the peripheral nervous system. So this is a myelination, so it wraps around the axon of the motor and sensory nerves to form a protective covering around that. And it also helps to speed nerve transmission. Now, more than that, there is so many other functions of the Schwann cell. So it conducts the nervous impulses, it helps nerve development and regeneration. So when a nerve is injured or damaged, it's the Schwann cell that's going to help repair the nerve. It has the trophic support, so it helps to nourish the axon, the neuron, and the production of extracellular matrix. Again, there's just with nutrition and support and protection, and it modulates the neuromuscular synaptic activity. So Schwann cells are extremely important. But so again, and this talks about this, it's a glial cell. So this maintains the homeostasis, forms the myelin, and protection for the neurons themselves. So the four main functions of the Schwann cell or the glial cells is to surround the neurons to help hold them in place, nutrients and oxygen. It insulates the neurons from one another, and it helps to destroy pathogens and remove dead neurons. So if a nerve is being repeatedly traumatized and damaged, these glial cells are going to go into mass, they're going to be activated, and they are going to do everything in their power to protect that neuron. So it is this actual tumor that we're talking about in a neuroma is this overactivity of the Schwann cell. That's the basic part of this, because again, it's important to know that. So why is it that we have a child who has a perfectly normal, if we look at their third inner space, we would see just a normal diameter of the intermetatarsal nerve. Then we fast forward till they're 40, 50 years of age, and then all of a sudden they develop this huge mass that becomes extremely painful. Why does it become painful? Because you have this swelling of this hyperproduction of the Schwann cells that's now crushing on the neuron that is within the nerve fibers. And so pain is a warning signal that something is wrong. And so simply this neuroma is saying, hey, we got an issue down here and I need help. I can't deal with it anymore. So there's been a lot of published data looking at the etiology of intermetatarsal neuromas, and it's basic. I mean, I don't think that there's really any argument as to why this happens. again, it happens for a reason, and it's mechanically induced. Because obviously there's no other form of trauma to the nerve. It's not like the nerve, like if you've slept on your arm and you made the nerve go to sleep, or you had a tourniquet around the nerve or something like that. So this is a mechanically pressure-induced degenerative neuropathy. The reason why we call it degenerative is because it leads to nerve pathology. It leads to nerve dysfunction. And so then we get this regeneration, degeneration of the nerve. And again, and the glial cells were just there trying to help this. Meanwhile, we still have the underlying etiology that continues to inflict more and more of this mechanically induced trauma onto the intermetatarsal nerve. So that's what we have, all these articles. And again, I went through and did a really exhaustive search. And it's also, we can call this an entrapment neuropathy. This is somewhat like plantar neuropathy. It's the same thing, it's just located in the inner space. So plantar neuropathy is where the posterior tibial nerve and the tarsal tunnel and the porta pedis goes through the same exact phenomenon. And it has, very little to do with the diabetic part of things. And it's really funny because, when somebody develops the same symptoms and the plantar aspect of their foot, we call it diabetic neuropathy, regardless if they have diabetes or not, typically. But then when they have this other form of neuropathy in between the intermetatarsal space, and we call it Morton's neuroma. So this isn't a lecture about plantar neuropathy. But so it's just this repeated nerve damage. So what does the literature tell us? Well, it tells us that the underlying cause of this nerve damage, this neuropathy, stems from a faulty foot structure that can cause increased stiffness within the intermetatarsal muscles, because that creates a weakness in the forefoot. So whenever there's a weakness, the ligaments are strained. That then sends a signal to the central nervous system, to the muscles within the leg and the foot to stiffen up the joints. So that is going to cause the dorsal fascia to increase its rigidity, and that's the deep intermetatarsal ligament. Then that creates this chronic rigidity of the dorsal fascia, increased stiffness within the intermetatarsal space. The nerves become entrapped when people are walking, and with the cumulative number of steps that we take, which is 8,000 steps a day, multiply that by days, weeks, years, it adds up significantly to millions and millions of steps. So that by the time you're 40 years of age, you've taken about 70 million steps. So even if you have just a small amount of excessive trauma that's occurring to this nerve 70 million times, well, yeah, eventually it's going to protect itself. So what do we see is that within the nerve, we have all of this. We have this nice healthy nerve here on the left, and then the destroyed nerve on the right due to the chronic inflammatory reaction. So the nerve is just absolutely being destroyed internally. And so that's why then we get this pain, is because the nerve is crying for help. So we can just see that there is a reactive nerve defense mechanism that ends up forming this tumor of the nerve, this protective sheath of the glial cells. Now, a lot of times initially those initial defense protective mechanisms, just like when somebody develops a callus, it's protective. But then that callus keeps getting thicker and thicker and thicker. So what turned into initially a good thing ends up being a bad thing. Then we end up with this ulceration. Okay, so all defense mechanisms are supposed to be temporary, not long-term. So this is where then we get into this whole nerve reaction destruction cycle, because of the excessive traction by surrounding the structure and with this mechanical damage from the sheath. Then we get the proliferation of the fibroblast and then also the glial cells. So again, swelling up, which then puts more and more pressure on the nerve. Now, there's kind of been this whole debate as far as like, well, how do you really diagnose this? Yes, we have molar sign, but not everybody has a positive molar sign. And of course, you're going to take x-rays to rule out a fracture. We need to see, there's a lot of different things that can lead to, well, I shouldn't say a lot, but we need to make sure to rule out a tarsal tunnel syndrome, which is the compression of the posterior tibial nerve within the tarsal tunnel, also portopetus. It's possible that people could even have back issues, and that's going to show up in the ball of their foot. So you need to definitely rule out other things. But there's this whole debate about, do you do an ultrasound or an MRI? Ultrasound obviously is less expensive and less time consuming than send somebody for an MRI. But you don't always pick up the neuroma on an ultrasound. And so that's why sometimes the MRI can provide a better quality. And that's all fine and dandy, but how does that really direct your treatment of the patient? So, and that's really the next point of this. So when somebody comes in with this burning pain in between their third and fourth toes, what are you going to do? Well, a lot of people are going to give them an injection. So do you inject them in the plantar aspect of the foot? If it's my foot, no thank you. And dorsal, so there's a whole debates on how do you inject them. And then when that doesn't work, a lot of options then are just to go in and cut it out. So then do you cut it out from the plantar aspect of the foot, the dorsal aspects, there's pluses and minuses of all of that. This seems to be the extent of our treatment, is just to go in and identify this kind of thing. So yeah, okay. But does this make sense? This is like the search and destroy. And, in my residency, we went in there, we were cutting out all kinds of things, and you're like, I don't really see anything, but, you just do a spacectomy, what they call it, and you hope to God that whatever you send to pathology has a nerve in it. But, it typically ends up with a search and destroy, just go in and cut out wherever you can, and then people end up with cut small tendons within their toes, and they get crossed over toes and all of that stuff. But anyway, so let's go through, and I want to look at the current literature, which helps to develop the standard of care in the treatment of these kind of conditions. So this is a study for foot and ankle, the Journal of Foot and Ankle Surgery, 2019, so it's very, very new, looking at the non-surgical treatments of Morton's neuroma, and they did a systemic review. And so they came up with 486 studies. From that, they got whittled down to 38 or 22 for final review for non-surgical treatments. They looked at steroid injections, alcohol injections, shockwave treatment, radiofrequency ablation, go with cryoablation to freeze the nerves, inject some capsaicin, some Botox, orthotics, and lasers. So they looked at all these different non-surgical treatments, and basically the conclusion of the study was that the steroids seemed to do the most help, and that all of the other things need much better studies. And I always say that. It's always a cop-out. No matter how many studies you have, it's like, we need more studies, never enough. But I just think it's interesting that, that with all of these significant studies or treatments, that the best one that they came up with is a steroid injection. Now, to me, the steroid is treating a symptom. None of these treatments affect the underlying cause of the mechanical trauma to the nerve. So, again, that's like great, but what about the underlying etiology? And this is the problem that I have with the majority of these studies. So here's another systematic review from 2018, and they only followed up the patients with this for at least 6 months. So, I mean, if you gave some kind of an injection, a sclerosing injection, or you did radioablation that just shut down the nerve, well, it's going to take a while for that nerve to grow back. And peripheral nerves grow back. So you need to have, there should be a minimum of 2-3 years to really see if these treatments are effective or not. If it's less than 3 years, 2-3 years, well, that doesn't really tell us anything. That's an introductory study. That doesn't show us anything. So that just tells us an initial gut reaction of this thing. So anyway, yeah, so that's that. So, and then we get into the sclerosing alcohol injections, which again, doesn't make any sense whatsoever. And that's what this study found, was that there's low level of evidence that shows that this does anything. I mean, think about it. Basically, you're putting a toxin to try to kill the nerve. And we have these peripheral nerves with the glial cells that are in there that love it when the nerves are trying to be killed, because then they go into action. They're waiting to go back in and reform this nerve. And we still have the mechanical trauma that caused the nerve to become damaged in the first place. So when we do a sclerosing injection, that's kind of like wrapping some tape, duct tape around, or whatever, electrical tape around a hose with a hole in it, and thinking that that tape is going to last forever. Well, it's only a matter of time before the adhesive becomes weakened, and then you have the water spewing out of the hole in the hose again, instead of out where you want it to come from. So this study found that there's insignificant research to show that sclerosing injections are effective. And the insurance companies say you get one shot. And if you give more than one injection into somebody, then that's overutilization. So a lot of people are getting into trouble with the insurance company because they give multiple injections of the sclerosing agent. Radiofrequency too is pretty cool, because I mean, that seems like, you go in there and you zap the nerve, you completely shut it down, and then when it reboots, hopefully then there's less pain. But the problem with radiofrequency is that if you don't, what does that do to the nerve tumor? What does that do to help with the mechanical induced trauma that led to the neuroma formation in the first place? It doesn't do anything. And then here's this study that they looked at how many treatments does it take, how many cycles, and is it 2 versus 3? And they did follow up the patients for at least an average of a year. And again, it should be much longer than an average of a year. It should be a minimum of 2 years to truly document the results of this. So, if you zap them 2 times or 2 times, they didn't really make any difference. They need more studies. So they need to have much longer follow-up. Is it better than just going in and ripping out the nerve? Yeah, definitely. But I think we need to do more. Something's missing with the treatment protocols. Here's another study. Again, I don't want to get too crazy into all these studies, but it's important to document the story that we're trying to tell. And these researchers have spent a lot of time researching and publishing their work. And so it's good for us to know about this stuff. Because a lot of us are just too busy to go through and read it. So that's why I spent the time and put together this PowerPoint for you. So what this study is looking at the prediction of the clinical prognosis depending on the distance and neuroma size using ultrasound. And the conclusion of this one was that the size of the nerve tumor is the sole predictor of whether a steroid would work or not. And so it kind of makes a lot of sense, because if you have this massive tumor, how is the steroid, the medicine, going to get down? And with the steroid, you put in an anesthetic, so that numbs the nerve. So right there, that's going to have an effect. But do we think that this is going to fix this nerve tumor permanently by giving them an anti-inflammatory injection? And again, we still have, and I'm going to be a broken record, the underlying mechanical trauma is present with every single step. So you give these people an injection, they feel great, they go out and do a lot of walking, which is counterintuitive because it's now destroying the nerve even more, because every step that they take, more nerve damage is going to occur. The steroid does not reverse that whatsoever. So here's another study, 2018, just again, another literature review looking at stuff. And this was talking about what the really important part of this study is looking at the failures. And it said too, like non-op treatment is very rarely successful, which makes a lot of sense. And I think that success rate significantly goes down because the longer you follow these patients, the larger that their nerve tumor is going to continue to grow until it has to be cut out. So what are the failures that were documented in this literature review? Wrong diagnosis, somebody that had a tarsal tunnel or a nerve lesion in their back. They went in to the wrong interspace. Mulder sign. I mean, you got to do a little better workup on that one. They didn't even go in and get the nerve. They didn't release the deep transverse intermetatarsal ligament that was crushing on the nerve. And again, where did they cut the nerve and so on? or they didn't completely remove the nerve. You want to go as far back as proximal and distal as possible. We're going to talk about that a little more too, cutting out the nerve. And this study too, 2018, just again looked at the size of the nerve itself and said that if it's greater than 6.3, that the steroids are absolutely useless. So that's kind of important to know. Let's see. So, and again, let's get fancy. We're going to give somebody an injection under ultrasound guided alcohol injection. Like that's going to be any more effective. These neuromas are basically all in the same location. It's very rare that you find them, say, more proximal. I mean, it's almost, you can guarantee where these are going to be found. So the conclusion of this study is that they came back even after they had the ultrasound guided. You can charge extra for this, or it looks so cool when you're there with your ultrasound giving somebody this injection. But the conclusion of this is that the symptoms came back because the same underlying etiology was still present. Okay, so you guys can see where this theme is going. More of the same. I'm going to skip through this because just over and over, but these are just recent studies. This one showed that steroids plus the local wasn't any better than just the local anesthetic alone. Because, and that makes total sense, because if you just give the local anesthetic, you knock out the nerve, that steroid is not going to shrink the nerve. It just doesn't. Another study looked at, what was this one on? The patient-reported outcomes for excision of the nerve. And it said that they're not that great, that only 63% of the patients in this study were pain-free at the follow-up of this, and the follow-up was not very long. It was only about a year, I think. So that's pretty crazy. So more recently, what we've gotten into is, before we just go in and cut out the nerve, let's do a nerve decompression. And that makes a lot of sense. And even though this is first published back in 1979, it seems like we've been trying to do everything else instead of this. And that goes back to the whole plantar neuropathy, where we need to go in and find out where the nerve is being compressed and decompress it. Otherwise, you can take all the pills in the world, but your nerves are going to continue to get damaged. It's the same thing for intermetatarsal neuromas. We've got to go in and release the nerve, but more than that, we need to eliminate and discover what causes the underlying mechanical trauma to that nerve. We're going to eventually get there. Just hang with me. So this is another study, again, published in 2020, looking at the decompression, but the follow-up was only 6 months. And it was only 12 patients, so this is not a very long study. And it was positive. They had positive results, but what's going to happen long-term? The mechanical trauma is still there, so we can't expect that this is going to have a success. So going in and decompressing the nerve is great, but there's going to be reoccurrence because we did not eliminate the underlying etiologic factor. So there's a major flaw in our current treatment of intermetatarsal neuromas, because you can inject it all day long, you can zap it, you can decompress it, but we still have the mechanical underlying etiology is still present. So we need to think about that. We have this symptom, we have pain of the water coming out of the hose, or the pain coming from nerve trauma, and the cause is because there's a hose, there's a mechanical trauma. So what we need to do is to eliminate the underlying cause. If we patch the hole, then the symptoms go away. So to simplify this, we have a faulty foot structure leads to the formation of an intermetatarsal neuroma. And it's so simple. I mean, think about it, especially for the third inner space. So when the foot becomes hypermobile, the third and fourth metatarsal bones are going to go from vertical to oblique, and then that is going to create this mechanical trauma to the intermetatarsal nerve, combined with the constriction, the tightening of the deep transverse intermetatarsal ligament. And then you start multiplying this millions of times, and of course the nerve is going to start swelling. And it doesn't take a lot. So the reason why I'm showing this study, get back in 2018, it showed that it's only a very, very small increase 2.18, I don't know how they measure that, of an increase in the intermetatarsal angle is going to be an abnormal widening, and it's almost even undetectable, but that can then lead to the trauma to the intermetatarsal nerve. So let's get now into the real meat and the real discovery of the treatment of intermetatarsal neuromas. And that brings us back to the hindfoot in overpronation, hyperpronation, and the mechanical instability. Where does that start? Where does the beginning point of that? And of course, it has to do with the stability or instability of the talus and the calcaneus in the navicular. So it's talotarsal joint instability. There's a partially dislocating talus is going to push the medial column of the foot. It's going to weaken it. It's going to push it away from the lateral column. That is then going to tighten the structures in between the third and fourth intermetatarsals. This creates micro nerve trauma. It's that simple. That's where it starts. It starts from the hindfoot. So you just see how with every step there's a micro trauma. So it's not severe every single time. It's just little by little, little by little. And that nerve is just being, just like a callus, it just forms just over a prolonged period of time. So what ends up happening is that the nerve kind of has that knee-jerk reaction with the glial cells are having the swelling. They feel they got to protect that neuron. And so you have the scar tissue that's forming, within the nerve, the glial cells are swelling. And so this then takes us through these various levels of nerve injury. So most of us only take the x-ray of a foot, and you cannot view the foot as a static structure. You have to think of the foot as a dynamic structure. And you put the patient's foot into neutral position with the talus aligned on the calcaneus. And you should really take the two sets of x-rays that I always talk about or use fluoro. Weight-bearing fluoro should be the standard of care with biomechanical imaging of the foot and ankle. So look at how that the metatarsal heads are being pushed distally, and just think about the tightening of the inner space, because that deep transverse intermetatarsal ligament is going to tighten, and then that is going to traumatize the nerve. So I have like a couple of images in here. So just, it doesn't take a lot. It's 2 degrees or less of motion in between that. And so that's why that third inner space is always the most common, because of the medial and lateral columns of the foot. I don't want to skip over this. Let's go back. So here we are. So that's why this isn't just limited to the third inner space. The reason why this phenomenon can happen in other inner spaces is because of that excessive talar motion. Okay. So, and that's why in the previous study, they found that orthotics, plantar foot orthotics, are incapable of having any kind of long-term effect to the formation or the prevention of intermetatarsal neuromas. It might be able to help a little bit, but the problem is that no matter what you put under the bottom of the foot, it cannot stabilize and align the talus. And I'm not saying that there should be a contraindication of using an orthotic. Of course, patients should be prescribed those. But we have to acknowledge the limitation of putting on something on the bottom of your foot to control the talus. It just cannot do it. There's no literature to show that. So meanwhile, every step that these people are taking, they're thinking that they're walking with this $800 foot orthotic that's curing everything, but it's not. We still have the same mechanical trauma that's leading to nerve damage. So here's like a better of a blow up. So look at this foot is going from neutral position into relaxed stance position. And you can just see how there's a widening of the inner space. So it's happening between the third and fourth, but this one is between the third and second metatarsals. And you can also see, you know, another webinar series coming up is looking at first ray disease. But I wonder what happened, what went wrong there. So you know what I'm going to talk about. I'm Dr. HyProCure, right? So what we need to do is, you can give all the injections and everything else, and that's great. But we need to focus on fixing the underlying cause. That's where HyProCure comes in. Because once we stabilize the talus on the calcaneus and navicular, then that stabilizes the medial column of the foot, and instantly, those excessive forces that were acting within the intermetatarsal space is reduced, normalized. And, you know, again, we're not saying that you put in a HyProCure and their metatarsal neuroma is going to be cured, but now when you do the radioablation, the cryo, whatever you want to do, give the other injections, now they're going to have a chance because we've eliminated the underlying etiology. It's kind of like you keep putting new tires on your car, but you never balance the tire, the wheel, and so the wheels wear out. And so you have to balance the tire. So that's what we're doing when patients come in with this nerve condition, is that we are solving their entire foot problem. We're not just focusing on symptoms. So the EOTTS HyProCure functions back here at the etiology versus all the other treatments that are looking at the symptoms. So we know that, you know, again, we've looked at biomechanics of this, and people have observed this, that biomechanics definitely play a role, but we just don't know the second step of it is how to fix that. And this study showed that the orthotics and shoe modifications just didn't give any results. That's because they don't stabilize the talus. Same thing here is there's just, after a year, there's just no significant follow-up, that the patient just keeps getting worse. So using something like HyProCure just totally makes sense, because it's going to stabilize the medial and lateral columns, decreases the strain on the deep transverse intermetatarsal ligament, decreases the strain on the nerve. And of course, it's going to have a positive effect to the tarsal tunnel, portopedis, and decrease the elongation of the nerve. So it helps with so many other things. And that's why if you only address the symptoms, this should be below the standard of care, because you're not fixing anything. It's so crazy. It's just absolutely ridiculous to just give them injections of something that we know is not going to help. To give them a sclerosing injection, and we know that the nerves regrow. To cut out the nerve, we know that there's a high risk of recurrence of a stump neuroma, because that nerve is going to grow. It's going to keep growing out until it connects to the cut portion. That's what it's designed to do. So that's why before we start going in there and cutting out these nerves, let's do something that makes a lot more sense, that is evidence-based as far as the ideology of why we should stabilize the subtalar joint. Of course, we know all the other many positive effects of HyProCure on the plantar fascia, the posterior tib tendon. It helps to relax the flexor tendons, and even, you know, the lumbrical interosseous muscles will be relaxed because the forefoot is going to be strengthened. It's going to have a positive effect for functional equinus, first ray, plantar neuropathy, and then of course the rest of the body. So when somebody has that partially dislocating talus, they're going to have symptoms to the rest of their body. So you always need to make sure to ask patients when they come in, don't just focus on that third interspace, ask them about their knees, hips, or back, because we want to look at the entire musculoskeletal system with them, and realize that the partially dislocating talus is going to affect more than just that third interspace. So I think that this should make perfect sense. So now when that patient presents to your clinic with that burning in between their third and fourth metatarsal bones or other interspaces, that you're going to now not just focus on that interspace, but you're going to look back at the talus to see, is the talus aligned or misaligned? And 99.9% of the time, you're going to see pathologic alignment of that talus. So don't forget that peripheral nerves do regenerate, and that's why we get these neuromas to form. When you cut out that nerve, it's going to regrow, and you can end up with a worse situation. If you've been in practice long enough, you're going to have patients come to you from other doctors that have had their neuromas cut out, and it's back again. So how many times are you going to go in and cut it out? What makes you think that the way that you cut out the neuroma is going to be any better than your colleague? To cut out the nerves, cut out the nerve. But let's look at the underlying etiology. So when somebody comes in with this burning, tingling in the ball of their foot, and you've gone through and you've diagnosed them of having this neuroma, then the first thing you should look at is an effective proven way that you can stabilize the hindfoot, which is then going to take away the mechanical strain, the underlying etiology to the nerve trauma. Then, so we're going to stabilize the hindfoot, and if they're a candidate for HyProCure, then great. If not, then you have other treatment options. At that point, depending on how bad the nerve is, you can just put in a HyProCure and see what happens. If their symptoms are super severe, if they have a large neuroma because you've gotten an ultrasound or MRI, then you can go in and decompress the nerve. Don't just go in and cut it out, because if you decompress the nerve, then you're going to increase the space there. And because we've eliminated or reduced that excessive trauma on the nerve, then the nerve swelling should decrease itself. Just like when somebody has a callus under the ball of their foot, and if you perform an elevation osteotomy of one of the lesser metatarsal, whatever bone, that callus will eventually just go away because the skin doesn't have to produce it anymore. So you always want to save nerve excision as a last ditch attempt when everything else has failed. So I hope that makes sense to you. And, but this isn't the end of this lecture, it's just the beginning. And what we need to do is to get studies that now show the positive results of performing HyProCure procedure in these patients. And we have to document the results, and whatever we can do to help gather that data and to publish it, please, let's be proactive and do that. Because so many people are out there suffering with this, getting injection after injection. And imagine that, you know, you're supposed to have 6 months of conservative care before you go in for any kind of surgical correction. Well, that doesn't make any sense, because that's you know, 6 months is you know, 180 days of them walking and causing more nerve damage. So that just doesn't make any sense whatsoever. So we had a question of, when you stabilize the hindfoot, how quickly can symptoms go away? That's a great question. It all depends on how large the nerve is. And so, you know, sometimes the symptoms can be right away, because think about the fact that when patients are off of their foot, they have no pain. And it's when they're up and walking around, I mean, obviously if you're pushing on the nerve, it's damaged, so it's going to cause pain. But unless they're walking, they usually don't have any pain. So if we can stabilize the hindfoot and prevent the metatarsal bones from smashing into the nerve, then the symptoms could resolve almost instantaneous. But if the nerve is so large that you need to still go in and decompress the nerve, well, it's going to take longer. But you want to give, like most other things, I mean, if it's me, and if somebody has such severe pain that they don't want to walk at all, then I'm going to do both. I mean, it's a small incision and minimal recovery to go in and decompress the nerve. I mean, if you wanted to do both at the same time, why not? But if somebody's symptoms are more mild, and then you could give it a chance. You could say, let's just go and put HyProCure in, and if we had to, we can go back and perform the second surgery. And most patients are going to say, yeah, if you only need to make one cut on my foot, I'd rather have one cut than 2 cuts, understanding that there's a risk that they have to go back for surgery. So anyway, so I hope that I was able to provide a unique look at intermetatarsal neuromas. And anyway, what I want to do now before I go is, and this is mainly for the international crowd out there, and for our domestic too, is in order for us to contact you with any other information, and if you want anything, please click on the poll here, so then that gives us permission legally to contact you. So it's just not a random thing. But again, the other thing too is to make sure to go to HyProCureDoctors.com to look for more information. We have several other webinars. I hope that you have found this to be very interesting. If you have any other topics or anything else that you'd like us to cover, please let us know. And yeah, that's it. So thank you. Have a great day, and good luck with everything. Bye-bye.